Hello, Dr. Robert Zivadinov, and thank you for being part of this taped interview, which is part of BioNews Services' official coverage of the ECTRIMS 2017 meeting.
Thanks for having me.
So, Aubagio was shown in the TOPIC trial to significantly reduce conversion to MS in people presenting a first clinical episode suggestive of MS. So, which disease signs were considered a first clinical event consistent with MS? What are you looking for?
Yeah, so TOPIC particularly evaluated these patients with the first onset of the disease. First of all, the onset can be monofocal or multifocal, which means one part of the body or more part of the bodies are involved at the same time. There are usually three, I would say, cardinal symptoms of MS presentations. The most frequent one is optic nerve involvement and inflammation in the optic nerve. So patients with MS have visual symptoms. Probably 70 to 75% of patients have optic neuritis during their lifetime. But there are other symptoms, including those related to injury in the spinal cord, so motor symptoms or sensory symptoms, and or if the lesions are in the infratentorial brainstem part of the brain, clearly they would have balance problems, coordination problems, etc. So these three types are most frequent. Obviously, it depends also at which stage of the disease. I'm not saying at stage of the disease because many patients may just minimize the symptoms first time and go over the first attack that was not recognized. This was not the case of the TOPIC study, but I'm saying in a clinical routine, we see patients with already many lesions in their brain and bladder symptoms and other symptoms because they have not been diagnosed timely. For the purpose of the TOPIC study, it's important to say that patients were really selected at the first clinical attack.
So, might a person using Aubagio never actually convert to MS, or is the drug rather delaying a diagnosis and disease progression?
The drug is mostly delaying conversion to clinically definite MS. Unfortunately, I think that we still don't have any drug that show to stop the disease 100%, and certainly that would be a very important step in the future. But there was a significant difference of proportion of patients with both 7 and 14 milligrams of Aubagio treatment respect to conversion to clinically definite MS respect to placebo. And that was already published a couple of years ago, and clearly it was part of the FDA approval of the Aubagio for treatment of MS. I want to also note that this is so far the only oral trial that evaluated effect of treatment in patients with CIS, because there were no trials in CIS with other oral agents.
So, for how long have these patients been followed now?
These patients have been followed now for 4 or more than 4 years. So they have been, the original trial was 2 years long with assessments at 6, baseline 6, 12, 18 and 24 months. And there was assessment now in year 3, 4 and 5 in extension of the study. So in the original trial, beyond the effect of the clearly reduced conversion to clinically definite MS, it has been shown that Aubagio also delays development of new gut-enhancing lesions and new T2 enlarging lesions. However, there are no reports of whether Aubagio in such a very early stage of the disease can delay or slow down development of neurodegeneration, and I can describe you why this is the first time that in this study and in CIS patients we looked whether an oral treatment can delay neurodegeneration.
But there are also trial results showing that Aubagio reduces loss of cortical gray matter in the brain by up to more than 40% compared to placebo.
So that was surprising to us, honestly, because first of all, I would say that there are two key points of the study we presented yesterday. The first one is a biological. As I just told you previously, it's very well known that development of new contrast-enhancing lesions or T2 lesions are associated with development of a second clinical attack. But until now, it was unknown that development of cortical atrophy can also predict conversion to clinically definite MS. As a matter of fact, we all as a community believed from the studies that cortical atrophy is a late-stage phenomenon in the disease. And there is very few data really for involvement of cortical atrophy very early on from the first symptom of the disease. So this is a first phase 3 trial that looked whether in a pooled analysis there was an effect of cortical atrophy on clinical definite MS development. As a matter of fact, in the analysis we presented, we divided patients in 3 groups: those who had very minimal cortical atrophy, less than 0.2% per year, those who had a medium atrophy between 0.2 and up to 1.8%, and those more than 1.8%. And there were significantly more patients with 7 and 14 milligrams in the Aubagio treatment arm who were in the low cortical atrophy group, and much more placebo in the high cortical atrophy development group. Now, independently of the drug use, those patients between group 1 and group 3 had more than 40% difference in conversion to clinically definite MS. So, and I'm even not talking about the treatment effect here, I'm just talking the biological effect that who develops cortical atrophy develops much more frequently CDMS. Now, if you look, and that was also part of the presentation, their demographic and clinical characteristics at baseline, they were almost identical in all variables. So we could not upfront say who is going to develop clinically definite MS. The second key point of the poster is obviously the effect of Aubagio on slowing down cortical gray matter atrophy development. So the effect was very early significant. Almost after 6 months of therapy, we found that both 7 and 14 milligrams reduced significantly gray matter volume loss. This was maintained in month 12, 18, and 24 months. So at all time points, both doses of Aubagio were significantly better in slowing down cortical atrophy respect to placebo. Now, this is certainly very impressive finding, and I can tell you that in my entire career and I published hundreds of studies on brain atrophy, I have not seen such a sustained effect of one treatment through all time points with all doses on cortical gray matter. This is very encouraging, but also in the same time poses much more questions. First, how we understand better the mechanism of drugs like Aubagio that can lead to that effect. Aubagio is a T and B cell inhibitor. We know very well that B cell immunity is much more important for the cortical atrophy development than T cell immunity. I think that this study may lead to better research and understanding of Aubagio into the B cell direction than into the T cell direction. Also, we know, and we publish separately from this study, that development of cortical atrophy is very associated with a virus called Epstein-Barr virus, which is one of the main probably contributors or causes of the disease. So the logical next step would be to look whether Aubagio may first, how does do that at the level of the cortical B-cell immunity, and B, at the level really of Epstein-Barr virus titer and humoral response.
So do you think that future clinical trials will focus more on examining effects on cortical atrophy?
Definitely. I think that's becoming a standard now for all new molecules coming out. I have to mention that patients who develop more cortical atrophy are definitely those who develop more cognitive disability and physical disability. So to slow down cortical atrophy is definitely an important aim of the future treatment strategies. Definitely.
So it's not only a marker for conversion to definite MS, but rather of disease progression in general.
And that's you are coming to my previous point, that the importance of this topic analysis is extremely on a biological side, because it was known in later stages that cortical atrophy is contributing to disability and cognitive progression. This is the first study showing that cortical atrophy is contributing to development of CDMS in such a large population of well-defined CS patients.
But do these results suggest that also clinicians should start assessing cortical atrophy in their patients outside of trials?
So that's controversial, and for a couple of reasons. If you ask me, does a community neurologist can assess cortical atrophy in MS? The answer is no. The assessment of cortical atrophy is dependent on the high quality sequences you are going to obtain on MRI, on standardization that you have performed, and on the tools you are going to get to obtain the cortical atrophy. Certainly in some academic centers that's possible, and I think there will be more and more available tools off the shelf in terms of reports to evaluate cortical atrophy in patients. And if that can be provided to the clinician, that's more than welcome, because they will be able to make better decisions for their patients. However, there are also simpler measures that are reflective of cortical atrophy. One of them is lateral ventricular volume, whole brain atrophy, etc. Certainly it's not measurement of cortical atrophy, but they are like proxy of cortical atrophy development. I think we should take into account the take-home message for the clinicians from this study is that even in the patients they don't see development of new lesions, they have to take into account that there is another component ongoing very early on in the disease, and that's the development of cortical atrophy that clearly can lead to conversion of to CDMS and later cognitive and disability progression. And certainly to also treatment choice, because we definitely want to use treatments that can delay cortical atrophy. I did not mention, but just so audience understands, the basis for the cortical atrophy is development of these cortical sapile lesions in the third layer of the cortex that are invisible on MRI because they are not inflammatory, and they are probably related to leptomeningeal inflammation, and this brings us back to the whole discussion of meningeal inflammation in MS, Epstein-Barr virus, etc. So for Aubagio to be able to even work on these lesions that may not be inflammatory in their nature early on the disease is certainly very encouraging.
So how how early should treatment with Aubagio be started?
I would say immediately after the first onset. If the patients meet the criteria for high risk for developing MS, meets the McDonald criteria, we heard on this congress that criteria have been revised also to minimize the situation of false positives in patients who may be started on treatment and do not have multiple sclerosis. I think there is no reason to wait. We should start treating immediately these patients.
So what are your future research plans for Aubagio?
I definitely would like to better, and I'm committed to better understand the mechanistic effect, how Aubagio can lead to a decreased cortical atrophy in terms of better understanding correlation with Epstein-Barr virus and clearly immunologic effect. I would mention that apart from this study, we showed a small pilot study from Buffalo where we treated 30 patients with Aubagio and measured Epstein-Barr virus changes over 1 year. That was presented last year on ECTRIMS. And we found that major explanation of the slowdown in cortical atrophy in these Aubagio-treated patients was by decreasing the titer of the Epstein-Barr virus. So this is very preliminary pilot data to be confirmed in a larger phase 3 or 4 study. So the next logical step would be to try to see what's the connection of Aubagio treatment over 2 years and humoral response to Epstein-Barr virus in relation to cortical atrophy development. So hopefully this may be done by next ECTRIMS and we may meet again. This would be really a big finding. If that's true, would be a huge finding.
Indeed, it would. And then it also comes back to what you mentioned, Aubagio's effects on B cells that you might want to explore more.
Absolutely, yeah.
So is there anything else that you want to talk about or elaborate?
No, I'm okay. Thank you.
So thank you so much.